Professor, Physician, Epidemiologist. I am Dr. Sri Banerjee. Hello, I'm Dr. Sri Banerjee, core faculty for the College of Health Sciences and Public Policy at Walden University. And in this video, I'll be going over polypharmacy and chronic disease. Pill bottles rolling and pills rattling is a common daily ritual for many people who take pills for multiple conditions. It's not uncommon for people to be taking over 5 medications at one time, and aside from popular belief, it's actually pretty common also for in younger adults to be taking this. Not as common in older adults. So these are kind of some of the patterns that you would be thinking about when you're thinking about polypharmacy. I'm gonna then tell you more about what polypharmacy exactly is, and then go through a scholarly journal article to see how we can use this new approach, a different approach to understand chronic diseases. So let's get started here. Okay, so polypharmacy, as I said earlier, is considered when somebody takes 5 or more pills. Typically, an average of 5 to 9 drugs among older adults, older Americans, is not uncommon. And of course, many adults have diabetes, hypertension, sleep disturbances, and sleep alone can consume quite a few pills. So when you have all of these conditions together, even high blood pressure, many people take multiple pills for this condition. So this can also lead to malnutrition and also many drug interactions which I will go over in the second segment. So bottom line is polypharmacy increases the risk of adverse drug-related events in older adults. And what are the reasons why? Well, higher number of drugs come with a higher risk of harmful drug-drug interactions. So the more pills you take, the more likely you'll have interactions. And that's the first principle. The second is the aging process is associated with physiological changes. So initially it may be that you gain weight, but after a certain age there's weight loss, there's deterioration of liver and renal function and excretion, there's decrease of cardiac output, there's body composition remodeling, so body weight, body fat redistribution is something that is seen more commonly, and that makes older adults more prone to adverse drug outcomes. And so the high prevalence of chronic multimorbidities in older adults, this leads to an enhanced risk of drug disease interactions. So it's not only that there's there's adverse drug reactions, but there's also enhanced risk of drug disease interaction. And so there's 2 different things right here, but important to note. So in this next segment of this video, what I decided to do is I decided to go to the Journal of the American Medical Directors Association. And this was an article that was actually published a number of years ago in 2020, looking at it's a review article looking at the adverse outcomes of Polypharmacy in older adults. It's the systematic review of reviews. So it's a good review, and it's coming out of the United Kingdom from Newcastle. It's the Population Health Institute there. So it's a good institute putting this together. So they start off by defining, and these are some AI features, by the way, if you're perusing through this journal article, where you can quickly click on this and take a look at the definitions as well. And I think in the context of polypharmacy, it would be worth our while to do this. So as you can see on the top, right off the bat, it's telling you polypharmacy is defined as the use of multiple medications by a patient, with 5 to 10 medications usually accepted as the cutoff. So these types of things can be seen in mental health conditions. Typical antipsychotics have quite a number of adverse reactions to be thinking about. And so, and those that are seen, and of course, if you've taken psychiatry or studied some of the drugs, you've seen that there are certain side effects that occur, like a tardive dyskinesia. Tardive dyskinesia that occurs about 4 weeks after you start taking an antipsychotic. Whereas certain conditions, like rigidity, you might find within a week of taking an antipsychotic. So and that's just a little snippet of what polypharmacy means in psychiatry. But polypharmacy in chronic kidney disease, get this, an average of 8 medications. If you're on dialysis, then that increases to 10 to 12. So one important point I want to make here to note is that polypharmacy varies depending on the specific disease condition that you may be looking at. So again, this is getting more specialized here, but looking at 65 and older, since that this group makes 13% of the U.S. population, they use about a third of prescription drugs. And so as this number increases, in about 20 years, this increases to a quarter of the population. So 65 years and older will comprise a quarter of the population. Then half of all prescription medications will be taken by this age group. So among the elderly, about 88% use one medication. And so polypharmacy, roughly just over a third of patients have polypharmacy among the elderly. So that number is just over a third, and of course we're trying to decrease that number, and more importantly, address the adverse outcomes that are associated with these drug interactions. So some of these adverse drug reactions you can look at and kind of see the definitions and what the cost is associated, not only in specific conditions, but also looking in general. After all, it's important to note that it is estimated that adverse drug reactions represent the 4th leading cause of death in the United States and Canada, behind heart disease, cancer, and stroke. So, and this was back in 2009, but definitely something that is important and worth your while looking into. The World Health Organization has gone in and talked about adverse drug reactions as a response to a drug that is noxious and unintended and occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease, or for the modification of physiological function. So this is unintended and harmful. And they further classify this into classification type A, where these are, of course, side effects, and then type B. So these are dose dependent, and 85 to 90% of all adverse drug reactions come from type A. And so those are dose dependent, predictable. But the type B ones are the ones that are unpredictable, and those are the types, even though there are only 10 to 15% of them, those are not dose dependent. And so there's likelihood of misinterpretation of some of these side effects of allergies, and this can lead to pretty much a wild goose chase to try to narrow down on what drug specifically is causing the side effects. And I've seen this in the context of psychiatric patients. When I was working in inpatient psychiatry in Staten Island, I saw firsthand patients that had polypharmacy, and it was impossible to try to really understand and hone down on which medications were causing side effects in an individual with schizophrenia. The individual was in his 50s, and he had very very rarely did he have lucid intervals. There was a strategy that our team had devised in trying to go through each medication and narrow down and see which one is causing the adverse reaction. So I've just talked about not only psychiatry, but also how multiple disciplines are working together to understand the problem of polypharmacy. So let me now go back to looking at some of the other criteria, and as it pertains to polypharmacy. So the most widely used tool is the Beers criteria. And this is a screening tool to alert doctors to the right treatment. So when there's a risk of the use of a drug which outweighs the benefit, which clearly outweighs the benefit, sometimes it's not known. Sometimes adding that medication might actually improve outcomes. Then it's clear. But when you're looking at drugs, either with very narrow therapeutic index or very high toxicity levels, these should be used with a lot of caution. For instance, certain antidepressants, if they have a problem in cardiovascular disease, then to address those early is important. So, screening tool of older persons, potentially inappropriate prescriptions. That's another one. So start and then stop. Start focuses on ensuring that medications that are indicated likely do benefit and are not omitted in error. So making sure what's there is good, and we're not missing something. And with the Beers criteria and stop focus, that's on minimizing the exposure to medications for which the risks outweigh potential benefits. So kind of wrapping this all up, and trying to understand how all of these fit in the broader picture of chronic diseases. Now, this is what is important. And the question then is, how specifically is polypharmacy affecting health outcomes? And to understand that, we must understand some of the intermediaries that are having an effect. For instance, nutrition, and so maybe also there's nutritional supplements. Um, so there's a lot of different things that we should be thinking about. One, which chronic diseases are these prescription medications being prescribed for? Um, and then how do we prevent adverse drug effects? So going back to just briefly wrapping up the original study, looking at the findings of the adverse drug events um, on a broad scale, anxiety was there. There was positive association, and this was Amstar scoring used. So Amstar is a rating for the type of systematic review that was conducted. Um, and so looking at some of these types of adverse outcomes, anxiety was one. Of course, I guess BMI, there was no association here. But this is the list of adverse outcomes. So these were some were present. Anxiety, BMI, circulatory diseases, cognitive impairment, delirium, depression, disability, and functional decline, dizziness, dry mouth, and these are in alphabetical order. But as you can see, this can get quite complicated. So to put your hand on one type of adverse outcome or another, and then focusing on that may be your best approach rather than looking at all of them all at the same time. So if you're focusing on pain, you might want to just look at pain because that is a broad category. Multimorbidity is a broad category of its own, which I have lectured on elsewhere. Pain, of course, definitely. And then pressure ulcers. This is something that is a title and a topic of its own. So all of these have a lot. So it's more than just this list. That's what I'm trying to say. There's a lot of different um, components packed in here. So just now looking at some of the adverse outcomes, um, medication discrepancies, medication errors, inappropriate prescribing, non-adherence. So these are all issues, whether it's patient issues, service provider issues, something that got in the way between the patient going to the clinic, taking the medication back to their home, and then actually taking it. These are all of the things, and so they've listed about 10 items that could go wrong in between those two that I've talked about, and actually taking the medication. And then finally, this looks at this table, some of the adverse outcomes in terms of hospital stays. So increased length of stay, hospitalizations, medical costs, number of prescribers, nursing home placement. So all of these, hospital readmission, emergency department visits, all of these are indicators of how adverse healthcare outcomes of polypharmacy led to poor utilization. So the principal findings of this is important because it shows that polypharmacy and symptoms or diseases can be explained by the prevalence of different conditions um, in later life and established patterns of prescribing. Um, so circulatory diseases, pulmonary diseases, endocrine diseases, these are the types of multimorbidity clusters that are found in older populations. And so other associations, those may not, other associations are actually more likely to reflect inappropriate prescribing. So, for instance, Anxiolytic prescribing is many times tricky, and there's medicine adverse medicine management outcomes as well. Um, so polypharmacy and frailty are also associated. So there's so many associations, so many connections, that it's important when we're just approaching chronic diseases, we take a broad approach and understand that there are not only multiple conditions that the individual may be experiencing, but also that they may be having to take uh, multiple pharmacologic interventions, drugs, um, and therapies in order to treat the conditions that they have. And so when you have multiple therapies, multiple modalities, then you always have room for, unfortunately, adverse reactions, which then is a contributory factor for adverse health outcomes in chronic diseases, which then, of course, will also affect activities of daily living and health related quality of life. So these are all of the connections that you have to be aware of. Thank you for listening.